that I want to jump into is to talk to you about the evaluation and the management of thromboembolism in pelvic surgery. And why is this important? ACOG actually published a practice bulletin addressing this in 2021. That's a very good high yield practice bulletin. I would recommend you review and become familiar with what's in it. The reason it's important is up to 10% of our patients, our post-op patients, can develop a VTE. The problem with that is we need to be able to discuss to the examiner how we evaluate our patient preoperatively. What do we do to prevent a VTE? And then, of course, what do we do to manage it? And our risk of post-op VTE is truly only secondary to orthopedic surgery. So when we look at the risk factors for VTE, the first thing we have to think about, of course, is Virchow's triad. So what is that? It's stasis, it is vascular endothelial injury, and it is hypercoagulation. Other risk factors include advancing age. We know surgery for malignancy, the length of time of a surgery. The longer a patient is under anesthesia, so greater than 45 minutes. Obesity, which of course we see more and more in our patient population, not getting up out of bed early and walking around. And there's different medications that increase the risk of clotting. There's also different diseases the patient can have. And when it comes to the thrombophilias, which we're going to talk about next, 50% of VTEs that develop have an underlying thrombophilia, but then of course, personal and family history of thromboembolism is important. When we look at the different thrombophilias, there's a whole host of them, and you've got Leiden factor 5, the prothrombin, and they're all listed here. The vast majority of these are inherited. However, antithrombin deficiency is one of the few that can either be inherited or acquired. So let's look at Leiden factor 5 mutation. That was the first one that was actually identified, and it is the most prevalent. As much as 5 to 10% of the Caucasian population has Leiden factor 5. Again, we talk about 50% of the thrombophilias that are diagnosed will be Leiden factor 5, and they're involved in about 20% of the DVTs. Now, the mechanism of action is due to activated protein C resistance. So, of course, there's the protein C deficiency that can increase clotting. This is truly just activated protein C resistance. So it's a little bit different of a mechanism, but the same sort of a pathway. There's different tests you can do for the thrombophilias, and the exact testing is not that important. What I really want you to understand is that testing for thrombophilia is difficult, and it's difficult to interpret it. It can be affected by oral contraceptive pills, by pregnancy, et cetera. So really, you would not most likely be doing a whole thrombophilia panel, but doing it in concert with a hematologist, oncologist, or with an MFM. But regardless, Leiden factor 5, there's a genetic test you can do for it, or a functional coagulation test that is actually looking at the protein C resistance. Most of our patients will be heterozygote carriers, and the increased risk of thrombosis is 3 to 8-fold the normal population. Homozygote carriers are much, much rarer, and of course, they have a more significant increased risk of clotting. Next is the prothrombin mutation. It's like the second most common one, 2 to 5% of the general population, and about 5% of the DVTs are prothrombin deficiency will be a part of it. It actually causes an increase in the actual prothrombin levels. It is tested with DNA analysis, and again, the homozygotes will always have a greater risk of clotting than the heterozygotes. Now here's the protein C and the protein S deficiency. Again, they're much rarer, less than 1%. They're a very uncommon cause, and protein C is both a functional and a functional assay, so you're checking both quantitative as well as qualitative, where protein S is a free antigen assay. Again, please don't get overwhelmed with, oh my gosh, what if they ask me what type of test you do for that? That would certainly, if they ask you that, that would be well beyond general OBGYN board question. But what is important is that you understand that there are different types of tests that can be affected. by different pregnancy states, et cetera, and they're difficult to interpret. So anyway, again, here is the increased risk of clotting that you see with the different protein C and protein S deficiency. Now, antithrombin deficiency, we used to call this antithrombin 3. We're supposed to change the terminology now to antithrombin. It is very rare, but it is very dangerous. Only 0.202% of the population will have it. But if you have a patient with this deficiency, up to 85% of those patients will actually have some sort of a thrombotic event by 50 years of age. They have a 50 to 100-fold increased risk of clot. And it's kind of similar to von Willebrand's disease in that there are two different types. There's true antithrombin deficiency, just like there's true von Willebrand factor deficiency. And then there's the abnormal protein structure. And this should say type 2. It shouldn't be type 1 and type 1. This should say type 2. And so that you have adequate amount of structure present, it just doesn't work properly, much like the von Willebrand 2 and 2. So the diagnosis, you're going to check for an activity assay with the antithrombin. Now, something that we see much more commonly are antiphospholipid antibodies. So I'm not talking about antiphospholipid syndrome here. I'm truly just talking about the presence of antiphospholipid antibodies. And that's present in 1 to 5% of the population. And 30% of our patients with lupus will actually have a positive antiphospholipid assay. Of patients who test positive for antiphospholipid antibodies, about 1 in 2,000 will actually have antiphospholipid syndrome. And the clotting risk from just having the antibodies is variable. You guys know this, but again, if you test for antiphospholipid antibodies and 1 or more are positive, we have to check again at least 12 weeks later to make it truly be a positive diagnosis. The tests include lupus anticoagulant, which again is a functional assay, but the other two, beta-2 glycoprotein antibody and anticardiolipin antibody, are truly assays looking for IgM and IgG. Now we look at multiple mutations. Anytime you test for a thrombophilia, you're supposed to test for all of them because latent factor 5, protein C, and protein S, and anywhere from 15 to 30% of the time will have multiple mutations. And of course, what does that do? It increases the risk of clotting that much more. And we talked about they can be inherited or acquired. And the most important thing to remember, although we talk a lot about thrombophilias and the increased risk of VTE, anytime we have a patient who has a history of a previous VTE event, that is always going to be more significant than a carrier status, and it will trump the presence or absence of thrombophilia in our management of patients. So here's what's important. When should we think about doing a thrombophilia evaluation? Most patients don't need it. It is not needed for a first episode of a provoked VTE. So somebody pregnant who develops a VTE, somebody on OCP, somebody in a severe car accident. It's not indicated in somebody who has active malignancy, inflammatory bowel disease. This is the HIT thrombocytopenia, thrombosis, excuse me. So that's the heparin-induced thrombocytopenia, and we're going to talk about that in a couple of slides. And then you can see if somebody develops a retinal eye thrombosis with preeclampsia, that's not an indication for a thrombophilia workup, nor is a clot with myeloproliferative disorders. So when should we think about getting it, or when should we do it? If you have a patient who has a VTE and has a strong family history, a first-degree relative with a VTE less than 45 years of age, if you have a patient who has recurrent thrombosis, if you have a patient who has developed thrombosis in unusual vascular beds, and those are listed there. Even though we don't use warfarin quite as much as we used to, especially with some of the new DOACs and Eliquis and things like that, if you had somebody on warfarin who developed warfarin-induced skin necrosis, that is often indicative of a protein C deficiency, and that patient should be checked for that. And anyone who develops an arterial thrombosis, because most of these, we're talking about venous thrombosis, right? In arterial thrombosis, you're going to be thinking about antiphospholipid syndrome, and you need to rule that out. All right, so now we know about what can increase the risk for clots, but so what's more important? Preventing it. How can we prevent a VTE? Because prevention is always preferable to treatment. So before GYN surgery, routine VTE assessment on everyone using the Caprini score is recommended. And listed are the Caprini scores of what's low, intermediate, and high risk. And the whole thing we're trying to do preoperatively is look at our patient and figure out how do we balance the risk of VTE with the risk of bleeding. And the options that we have are mechanical prophylaxis and pharmacologic prophylaxis. What about diagnosing a DVT? So say somebody comes into the emergency room and they're complaining of, say it's one of your patients, she's on oral contraceptive pills and she's complaining of calf pain and swelling in one of her legs. So when we look for clinical presentations, again, it's usually going to be unilateral. It may be warm, it may be swollen, tender, venous cords, or no signs at all. The Homan sign, which of course is pain in the calf with passive dorsiflexion, is a very unreliable sign for the presence of DVT. The best sign is the difference in the calf circumference. So if you have a calf circumference that is more than 3 centimeters in diameter larger than the other one, that is the best clinical presentation or sign for suspicion of a DVT. So if we're clinically suspicious of that our patient has a DVT, what should we do? You should assess the probability with something called the modified Wells score. And I don't have it listed for the DVT, but I do have it for PE. So we'll be able to go over that. If their modified Wells score is low, then you should get a D-dimer test. And if the D-dimer is normal, no further testing is required. If it's elevated, that it's greater than 500 nanograms per milliliter, you need to get an ultrasound. If the modified Wells score is moderate, you can either get a D-dimer or an ultrasound. And if it's high, you get an ultrasound. So now I'm going to make this even more difficult. D-dimer is not very useful in recent surgery or in pregnancy because with both of those events, the D-dimer is increased. So we are rarely going to be seeing someone in the emergency room who just comes in with a swollen calf and we have to rule out DVT, right? Most of our patients are going to have had recent surgery or they're going to be pregnant. So for us, pretty much we're going to go right to compression Doppler ultrasound in order to make the diagnosis. Not that you can't get a D-dimer, but it's really not going to be very helpful in your further evaluation. So the first test of choice for the femoral and the popliteal veins are the compression Doppler ultrasound. It's not sensitive at or below the ankle. We rarely use contrast enhanced CT venography or MRI venography unless we're worried about the iliac vein or an inferior vena cava thrombosis. And a lot of times when I'm listing some of these tests that we may not, I'm a generalist, a general OBGYN, we may not be like, wow, what should I get next? This is where we would be getting the help from our radiology cohorts. All right, let's jump to PE. So what are some of the signs and symptoms of a pulmonary embolus? Well, the most common is dyspnea. Patients can also have pleuritic chest pain, cough, increased respiratory rate, heart rate, rales, and of course calf or thigh swelling, which is where the clot originated. You can see some EKG changes. They're not diagnostic. About 70% of patients will have some non-specific ST segment and T wave changes, tachycardia, and only about 10% will actually have any type of right axis deviation. So here's the modified Wells that we use for a patient with a suspected pulmonary embolism. Do they have clinical signs of a DVT? Is another diagnosis less likely than a PE? Is their heart rate elevated? Are they immobilized or had surgery in the past week? Have they had a previous DVT or PE, hemoptysis, malignancy? You can see the point score, you add up the points, and it will basically tell you if a PE is likely or unlikely. There's also a 3-tier scoring system where There's a low, intermediate, and high risk, but really for the general boards, this is a good way to think about how you would evaluate someone for a PE. So if you suspect a PE, patient comes in, maybe they're short of breath, pleuritic chest pain, et cetera, you're going to apply the modified Wells criteria. And then if it's unlikely, you're going to get a D-dimer test. But again, most of the time when we see our patients, they're going to be pregnant, postpartum, post-op, which you can see down in the very bottom here. I've talked about here where different elevated D-dimers can occur. So again, if it's negative, you've excluded it. If it's positive, you need to go ahead and get your CT angiogram with contrast. This will either confirm or exclude a PE, and it will also give you the diagnosis of what is causing them to be short of breath. Is it pulmonary edema? Is it pneumonia? If the PE is likely by the Wells criteria, you bypass any D-dimer, you go right to CT angiogram, and you actually go ahead and start them on anticoagulation while you're waiting to get that CT angiogram. And this just talks about it. It's the test of choice and the 95% sensitivity. All right, so medical treatment of a PE. Again, most of the time when somebody has a PE, we're getting help to assistance from our internist or hospitalist to help us with the treatment of a PE. But what we need to do is anticoagulate them, right? So heparin is preferred for patients who have severe renal failure, patients who are unstable with an acute PE, also patients who maybe there's a high risk that actual thrombolysis might be considered. Then heparin is actually the preferred agent. Again, you give them an IV bolus, and then you're going to check the activated PTT every 6 hours, and we would like it to be 1.5 to 2.5 times above normal. After they've been on it for 5 days, you can either switch them to sub-Q heparin or warfarin, and you're going to be checking the platelet counts because we're looking for heparin-induced thrombocytopenia. You can do low molecular weight heparin. And again, at 3 days, you can switch to warfarin or just continue with sub-Q heparin. The factor 10A inhibitors, we'll talk about these a little bit more. And then the DOACs, those are the direct oral anticoagulants. And we'll talk about those. I've got a few more slides on that will talk about the advantages and the disadvantages of those. And it's rare, and we would never be making a decision on this, but when would someone like a general surgeon consider doing an IVC filter? It's obviously for patients with recurrent VTPEs, high-risk thrombophilias, or for unstable patients where they can get directed thrombolytic therapy. This is an old slide, but it has some good points on it, good clinical points that I'd like to go over. So the difference of warfarin and heparin, first of all, it's in their mechanism of action, all right? Warfarin affects different factors in the clotting system. Heparin actually binds to antithrombin. I wasn't able to edit this slide. It doesn't let me edit. We don't call it antithrombin 3 anymore. So it binds to antithrombin, which inhibits the production of thrombin. Look at the difference in the size of these two molecules. Heparin is much larger, and because of this, it doesn't cross the placenta and it's not teratogenic, whereas warfarin is. You monitor them differently. Warfarin is monitored with a PT, whereas heparin activated PTT. And again, this should say 1.5 to 2.5 times control. And they've listed the doses for prophylaxis as well as therapeutic doses. You can reverse both heparin and warfarin. Warfarin's with vitamin K, and heparin is with protamine sulfate. So heparin's acceptable in pregnancy, no for warfarin. And the side effects that you can see here are fetal bleeding, stippled epiphysis, and some of here's where you see the teratogenicity, and the half-life is 4 hours. With heparin, you basically can see maternal thrombocytopenia and even osteoporosis with long-term use. The half-life of sub-Q heparin is 1.5 hours, but IV heparin is 30 minutes. All right, what about low molecular weight heparin? Well, it actually doesn't have to bind to thrombin. It directly inhibits factor 10A. It can be used for thromboembolism prophylaxis and treatment. It has a longer half-life than unfractionated heparin, so you can do less frequent dosing. There's no need for extensive or frequent lab testing, which makes it so much easier for our patients to use. In pregnant patients, you might want to check an anti-10A level every 4 to 6 weeks, but that's certainly not mandatory. Compared to sub-Q heparin, the risk for thrombocytopenia, osteoporosis, HIT, and post-op bleeding is decreased. It also doesn't cross the placenta and therefore is acceptable in pregnancy. And oftentimes when I'm doing mock orals, and I'll be asking candidates about why is insulin the preferred agent to use for gestational diabetes, they give me everything about glucose control, etc. But they always or oftentimes forget that insulin doesn't cross the placenta. So that's another thing that we use commonly that doesn't cross the placenta that you should remember. All right, what are the disadvantages of low molecular weight heparin? Well, you've got an increased risk for epidural hematoma. It has a longer half-life, so you've got to wait longer before an epidural can be placed. So more than 12 hours for prophylactic dosing or 24 hours for therapeutic dosing. It's more difficult to reverse, and it's contraindicated in patients with prosthetic valves, which again, we would have MFM helping us manage that patient. What about the DOACs, the direct-acting oral anticoagulants? Three of them are direct factor 10A inhibitors. One of them, the dabigatran, is a direct thrombin inhibitor. What's so great about them? They're oral, there's a fixed dosing, you don't need to monitor labs. It has a much more predictable anticoagulation effect. It has a rapid onset of action and very short half-life and less drug and dietary interactions. The disadvantages are there's no reversal agent. The short life, although we talk about that's great, it has a short half-life, rapid onset, that also requires very strict patient adherence and not be missing doses because they're going to lose the anticoagulation benefit. It should be avoided in patients with renal impairment and is contraindicated during pregnancy and breastfeeding. We don't have much data, but there has been seen teratogenicity in animals. This is my big groan slide for today. All this is to show that the clotting system is very complex, and the different medications we prescribe act at different points along the clotting cascade. That's truly all you need to know. All right, medical treatment of a PE. All right, so you're going to monitor it, and I've listed with heparin how you monitor it, the activated PTT, Lovenox. You can check a factor 10A activity. Maybe you want to test it 4 hours after you first dose it, but you don't have to do it on a regular basis. And of course, warfarin, we're going to check the INR with the target range being 2 to 3, the goal being 2.5 times elevated. All right, two more things. Beware the antithrombin deficient patient. So what do I mean by that? If you are using heparins, unfractionated heparin, heparin must bind to thrombin in order to be active in fact, to then inhibit factor 10A and prevent prothrombin from going to thrombin. So if you gave sub-Q heparin to the 0.02% of the population who is antithrombin deficient, heparin's not going to work. So you're going to be checking that activated PTT, and you keep upping the heparin dose, and it's not changing. So that's why you should think about that. What about HIT, the heparin-induced thrombocytopenia? One of the things that you do is you stop the heparin or even the low molecular weight heparin, and you change them to argatroban. And I promise you, there's 2 or 3 more slides, and I will go over heparin-induced thrombocytopenia. This just shows the action of the heparins. Again, heparin binds with antithrombin to inhibit factor 10A, which prevents prothrombin going to thrombin, where Lovenox just acts directly on that. So heparin-induced thrombocytopenia. So what is this? This can occur with either therapeutic or prophylactic heparin, but much more commonly occurs with the higher dosing and the longer dosing of therapeutic heparin. There's 2 different types. There's the benign reversible that usually you can see a drop in the platelets that occur around day 2, 3. It's very benign. It goes back to normal within a week, and it's just a transient occurrence. But autoimmune or true HIT is is truly an autoimmune phenomenon. So it can occur up to 5% of the time with unfractionated heparin. With low molecular weight heparin, it's 0.2% of the time, so much less common. You need to check platelets on day 5 of anyone who is on heparin or low molecular weight heparin. And so here's what happens. The platelet releases a chemical that's called platelet factor 4. Heparin binds to the where the platelet factor 4 is, and it creates this complex of heparin platelet factor 4 complex. And so what happens is the body sees this as a foreign substance. It makes heparin PF4 antibodies and destroys the heparin in the platelets. So you're going to see a decrease of platelet count. You would think they have less platelets, so they're going to bleed a lot. It is the opposite. It significantly increases their risk for both arterial and venous thrombosis. Once you have identified that, you stop the heparin and you put them on argatabam. All right, so how are we going to figure out what sort of perioperative thromboprophylaxis we should do? Well, we're going to assess their risk with the Caprini score. If we were going to pick one thing, the sequential compression devices are the most effective with the least risk. So how do they actually work? They limit venous stasis, which is one part of Virchow's triad, right? And they enhance fibrinolysis, so avoid the hypercoagulable state. The only thing they're not doing, of course, is preventing vascular endothelial injury, but that's how they work. We can put TED stockings on the patients. We want to get early ambulation. And then, of course, we have prophylactic pharmacotherapy with heparin or low molecular weight heparin. So here's how we're going to evaluate it. If somebody's high risk for VTE and an average risk for bleeding, you're going to do both. You're going to do pharmacologic and mechanical prophylaxis. If they're high risk for both VTE and bleeding, you'll start with mechanical first, and then once that bleeding risk subsides, you can add in pharmacotherapy. If they're moderate VTE risk with low risk of bleed, you can do either. You can do mechanical or pharmacoprophylaxis. I'm going to pick mechanical because they work equally well and there's less risks. If they're moderate risk with a high risk of bleeding, you're definitely going to do just mechanical, and low risk, of course, mechanical is preferred. All right, now we're going to jump to just some basic anatomy. And please, this is just just kind of a quick review. So if we look at the anterior abdominal wall, there's 4 muscle layers, right? There's the external oblique, the transversus abdominis, the internal oblique, and the rectus abdominis. Now, let's look at the arcuate line. So above the arcuate line, what I want you to see here is here's the rectus muscle, and you have fascia going both above and below the rectus fascia. So here's the linea alba, our nice, friendly, avascular and space that doesn't have any nerves and is where we're going to make our vertical midline incisions, right? Below the arcuate line, you only have fascia above the rectus muscle. Now, the arcuate line is also called the circular line of Douglas, and it is about 1/3 to 1/2 of the way between the umbilicus and the symphysis pubis. I'm going to go to the next slide here. So here you can see, here is the arcuate line. Above the arcuate line, you have fascia behind the rectus muscle. Below, you don't. What's really clinically significant here is at the arcuate line is where the inferior epigastrics pierce the rectus muscle sheath and enter and vascularize the rectus muscles. That's really the significance there. There's also something, it's called a Spigelian hernia that can occur just lateral to the rectus muscle. This can be a point of weakness on the abdominal wall. All right, now, when you're doing your laparoscopies and you're looking at the old obliterated vessels of pregnancy, the first thing you're going to see is the median umbilical ligament, or which was the urachus. This is an avascular space. So if you're doing laparoscopy, that's a good space that you can enter. The only thing, sometimes if somebody's had multiple C-sections, this could be, the bladder could be hitched up, and you should be aware of that. Here are the median umbilical ligaments. These are the old obliterated umbilical vessels, again, avascular. But the lateral umbilical ligament, here's where the inferior epigastric vessels are. And you can see here's where this is the backside of the rectus muscles. So if you're going to do a malar incision, we're going to be going and ligating these prior to cutting those muscles. And when you're doing laparoscopy, you are also going to be aware of where this lateral umbilical ligament is and where the inferior epigastric vessels are. This is just again, a good review of basic anatomy. It's navel toward the navel, right? Nerve, artery, vein, lymphatics. The blood supply of the ovary. So if you look at where the ovarian arteries come from, both come off the aorta, here and here. The venous drainage is what's different. The right ovarian vein drains right into the inferior vena cava, but the left drains into the left renal vein. What about hypogastric artery anatomy? Again, this is much less important now that we know that bilateral O'Leary stitches and ligating the uterine vessels is much more effective and much safer when we are addressing postpartum hemorrhage. So not as important now, but again, just to review that the hypogastric artery originates from the common iliac at the pelvic brim. You have the anterior division, which supplies the genitalia, and then the posterior division, which supplies other areas. Here are listed the anterior division branches. This is not a written test. They're not going to ask you to list the 10 branches of the anterior division of the hypogastric artery, but I truly am just trying to give you a good overall review. This is important, and this, they could ask you this. And what I want you to do, I'm not going to read all this to you. You can see very well, you know, the ureter is about 30 centimeters in length, half is abdominal, half is pelvic. But what I could see the examiner asking you, describe to me the anatomy of the ureter. And we all know where the ureter is. We shouldn't be doing surgery if we don't. And we could even draw it. But trying to actually explain it verbally is a little bit tougher. So what I would recommend you do is to practice stating out loud, describing the anatomy and the route of the ureter. So now let's talk about some complications, management or injury to the bladder, ureter, and bowel. And again, as I said, I've been reviewing case lists for over 10 years. And guess what? Complications happen. There can be injury to the bladder, to the ureter, the bowel. The examiner may ask you, you know, what's going to be important here. Number one, how and when did you identify it? What did you do once you identified it? How did you repair it, or who repaired it if you called in the expert? And what was your post-repair care? They may also ask you, looking back on this case, now that you've had this injury, when did it occur, and could you have done anything differently to maybe help prevent that injury from occurring? And sometimes it may not, there may not be anything. So let's look at intraoperative cystotomies. So you made it, you're in the bladder during surgery. What are some of the risk factors? Of course, previous pelvic surgery, especially if patients have had multiple cesarean sections, if they've had severe inflammatory disease, chronic PID, even severe endometriosis can cause issues with, especially if they've got on the anterior part of the uterus and on the bladder. If you have a huge pelvic mass that is totally distorted anatomy, and of course, there's operator experience. One of the things I ask the candidates a lot when I'm giving a mock oral, and I think would be a fair question during the exam, would be to say, at the time of hysterectomy, do you do routine cystoscopies? Why or why not? And you should be prepared to discuss and explain why you do whatever you do. There's like one camp that says we should, another camp that says, you know what? It doesn't identify the delayed injuries. It's one more surgery. It costs more money. It's patients under anesthesia longer. And then the other camp is like, yeah, but if we can identify something I didn't identify intraoperatively, it just happened, we can fix it then. So just be comfortable discussing what your practice is and why you do it that way. All right, so if we've got this cystotomy, now what do we have to do? Of course, you guys know this. It's all about where is the injury. If it is close to the trigone, we're going to have to do stenting in order to make sure that we don't kink those ureters when that repair is being done. If it's in the dome, we don't have to worry about stenting the ureters. You're going to close it in 2 or 3 layers, and listed are the layers and the type of suture and if it's running or interrupted. After you've closed it, you're going to check for leaks. You might insert some sterile milk or maybe methylene blue to make sure that you have a watertight repair. And you're going to do a cystoscopy and make sure that there's no sutures or any other injuries that you detect in the bladder. A Foley catheter can be left in place for anywhere from 3 to 7 days, and there is no standard like it must be for this many days. You just need to know and be comfortable with explaining after you've had a bladder injury, what is your practice, and maybe you do what your urogyn or your urologist recommends. And antibiotics are not indicated, prolonged antibiotics with a Foley in place after a bladder injury. What about a ureteral injury? All right, so you can see the rate of ureteral injury can be anywhere from 0.4 to 2.5%. To me, the most distressing thing is that only a third of ureteral injuries are discovered intraoperatively. So the most common sites of injury, and at the time when I'm telling you, you should be able to discuss the anatomy of the ureter. You should also be able to discuss the 4 areas that are the most common sites of injury and what is it that we're doing at surgeons at the time we're injuring it. Okay, one is clamping the infundibulopelvic ligament. The other one is when we're clamping the uterine vessels, when we're doing something with the uterosacral ligaments, maybe, and especially when we're plicating them. They have shown that when, like in my training and what I still do, when I do a TVH, I do a modified McCall's cultoplasty. And doing that, 11% of the time, I can actually kink the ureter, and 1.8% of the time, I can actually obstruct it by pulling those uterosacral ligaments in the midline. And then, of course, closing the vaginal cuff, when we're putting in those far lateral sutures, we're really close to where that ureter is coming from lateral to medial to insert in the bladder. And again, this is just a diagram of those 4 points I just discussed. And I don't need to talk about those again. All right, what are the type of ureteral injuries? Because there's several. We can entrap it with a suture. We can crush it with a clamp. We can actually transect it. Thermal injury is probably the most common and is probably the reason why only a third are diagnosed intraoperatively, because this damage is going to show up later. And then, of course, we can devascularize or have denervation of the ureters. So when we are evaluating a ureteral damage, we need to figure out the duration of the injury. So obviously, if it occurred and you diagnosed it intraoperatively, it's immediate. But if it's a week or 2 later, the patient comes in with clear fluid from the vagina, then the duration of injury is very important. The distance from the UVJ with 5 centimeters being the magic number. If it's less than 5 centimeters, we can do a ureteroneocystotomy. If it's greater than, we're going to have to attach ureter to ureter. And the other most important thing is, can the repair be accomplished without tension? So let's look at what the management options are. Now, for us as a generalist, I am never, and you should never walk over, try to repair a ureter yourself. We are going to call in urology or urogyn. So the urologist may come in, and the first thing they may do is they may go ahead and do stenting, and to try to see where the injury is and to see if they can pass stents. And what's kind of interesting, for a very small ureteral injury, if it's like less than if it's less than 5 millimeters, sometimes just leaving a stent in place for up to 12 weeks, it really will heal on its own. But for injuries of more than 5 centimeters above, you have to do a direct end-to-end reanastomosis, the ureterostomy, where they spatulate the ends, and you're going to leave the ureteral stents are left in place for up to 12 weeks. And even with this, up to 10% of the time, they can develop strictures, and the Foley catheter would be left in place for about 10 days. But all of this is going to depend on who repairs it. Okay, you don't have to memorize this. You just need to know this is the basic theory. But if you had a ureteral injury, you should know what your urogyn or urologist recommended for post-op care. And then for injury that's less than 5 centimeters above the UVJ, we're going to do bladder reimplantation. So here's just a picture of the ureterostomy. Here's a picture of the ureteroneocystotomy. Now, if the bottom line is you can't pull on that ureter and try to make it attached to the bladder and have that under tension, it's not going to heal. So if the injury is significant enough in size that you cannot do just spatulate it and attach ureter to ureter and not have it under tension, or do it to the bladder, now for sure you're calling an expert, but we called the expert already with any ureteral injury. So what can we possibly do to try to deal with that? We have to bring the bladder to the ureter because we can't bring the ureter to the bladder. So the psoas hitch is basically you're going to mobilize the bladder, you attach it to the psoas muscle, and you're going to bring it up so that the ureter is not being under tension. The Biore flap, you're basically doing the same theory. You're bringing the bladder to the ureter, but you're going to go ahead and elongate and create this lengthening of the bladder so it can be repaired, not under tension. What about bowel injuries? What do we need to be thinking about with bowel injuries? Well, the 2 times we're most likely to injure the bowel is on initial entry into the peritoneal cavity and during lysis of adhesions. So the considerations that we need to be thinking about is how large the injury is. The type of injury, was it a sharp injury or was it a thermal injury? Because thermal can spread a lot further than what we actually see. What about the location? Was it the small intestine, large intestine? Was it the terminal ileum? What's the vascular supply to the area of intestine that we've just compromised or damaged? And did we compromise that vascular supply? And then, of course, is there any fecal contamination? When the bowel is repaired, and again, as a generalist, I don't repair bowel. It's going to be our GYN-onc or a general surgeon. But we should still know if the examiner asked you, so what would you do if you had a bowel injury? Of course, we're going to say we're going to call in the expert, but we still should be able to describe what is the factors that the expert's going to be looking at in their evaluation of the bowel injury, and what are the options for repair. So again, we don't want to narrow the bowel lumen. So I don't care where the injury is, we want to close that perpendicular to the long axis of the bowel. We don't want to close it longitudinal to the bowel. It can be closed in 2 layers. You're going to close the mucosal, submucosal layer, and then the muscularis in the serosal reinforcing layer. You can do interrupted sutures, you can do continuous sutures, and there's multiple suture choices that are okay. Meaning you can do 3/0 silk, you can do Vicryl. And large defects can actually be closed with a staple device. And when there's a large defect, usually the general surgeon or the GYN-onc will decide this area of bowel is too damaged. I'm going to resect this damaged bowel and I'm going to reanastomose healthy bowel to healthy bowel. What about antibiotics? Okay, it used to be, oh my gosh, in the olden days, if we got into the large intestine and there was fecal contamination, that patient had a temporary diverting colostomy. That no longer is the case. If you get a small bowel injury, if the patient has had prophylactic antibiotics at the time for her laparotomy, there's no additional antibiotics needed. If you have a colon injury and she's had prophylactic antibiotics, you just need to add a dose to metronidazole. There are no post-op dietary restrictions, nor you don't have to do an NG tube. These are not needed routinely after a bowel injury. And you know what's interesting? You know how they figured this out about the bowel, that you don't need to do the diverting colostomy, et cetera? It was actually from gunshot wounds. And so they started just primarily repairing gunshot wounds to the intestine, and they found the patients did fine. All right, now let's talk about surgical wounds. So, what else is important? Once you have made a decision, well, let me back up here for a second. One of the things that is important when you do decide that the patient is a candidate for a abdominal procedure, the next important thing is to determine what sort of incision should you make, because you can truly, if you make the wrong incision, you can really limit your visualization, and this is going to increase complications. So you need to know if you made a certain incision and it wasn't big enough, what are you going to do to resolve that? And in hindsight, how should you have thought about that better? When should you do a vertical midline incision? When is a fan and steel okay? All right, so now we're going to talk about this. So, considerations in abdominal entry. Is there a large pelvic mass? If you have a 22-week size leiomyomatous uterus, are you going to make a little fan and steel, or are you going to do a vertical midline incision? So that's an important thought process. What about if the patient already has, say, a large incisional hernia or an umbilical hernia, and you're having to go in again? You can maybe incorporate that hernia and help repair it at the same time. What about the patient's body habitus? Is that going to make a difference of your consideration of abdominal entry? And what about dehiscence? Is one certain type of incision more likely to dehisce than the others? So here are our abdominal entry options. The midline, of course, is our classic entry. Good exposure, quick entry, less blood loss, nerve damage, and it's easy to extend if we find something we didn't expect, especially malignancy, etc. Now, the disadvantage here, we used to think there was an increased risk of dehiscence, but we really don't see that anymore, not when we're using the delayed absorbable suture like Maxon or PDS. And again, you guys know what the fan and steel incision is. You know what a churney is, where you're just excising the rectus tendon off the pubis. Again, you have to be careful about those inferior epigastrics. And then a maillard incision, and we looked at that when I showed you the arcuate line. The most important thing too is you must identify and ligate those inferior epigastrics lateral to the rectus prior to cutting that muscle. But that really does give you excellent visualization of the abdominal cavity. There's also another one that I've never used. It's called a Joel Cohen incision. It's a little bit more cephalad than a fan and steel, and you just make a straight line. It's supposedly you get less post-op fever, pain, blood loss, and OR time than with a fan and steel. But I personally don't have any experience with it. Now let's talk about laparoscopy. Now, again, I'm older, so we were very comfortable doing TVHs. But I would say of all the case lists I've reviewed so far this year, there are no TVHs on the case list. And if I look back over the last 10 years or so, there are less TVHs each year on the case list. And last year, maybe 5% of candidates had a TVH. So you guys are very comfortable. Your minimally invasive approach is to do something that requires abdominal trocars and ports. So because of that, you need to be familiar with the vasculature of the abdominal wall. If you look at vascular injuries with laparoscopic surgery, they're pretty rare. It's like 0.1 to 6 per 1,000 cases. But 15% of vascular injuries with a laparoscopy are fatal. And the reason is you got the aorta, the inferior vena cava, or the iliac artery. So most of the time, the injuries are not a major vessel injury, but they still could cause problems where you would need to convert from a laparoscopy to a laparotomy. So you're going to enter the preferable place, of course, is infraumbilically, where there's no vessels at all. And then you're going to insert the other ports under direct visualization. The first thing you're going to do, of course, is you're going to use the light intra-abdominally, and you're going to try to see where is this superficial epigastric and the superficial iliac circumflex of vessels. And so you're going to place those ports in such a way that you're not getting these branches. When you look at the injuries, however, the most common injury is inferior epigastrics, which of course are deeper, they're not in the superficial wall. And the omental and the mesenteric vessels are the ones that are most commonly entered on initial entry. All right, suture material. It's probably been a while since you've thought about a suture material and how it is broken down, etc. I'm not going to read through this. You can look through this on your own time, but basically just be aware of the strength of the different sutures that we primarily use. All of these are broken down by hydrolysis, and I just want you to see Vicryl, Dexon, PDS, and Maxon, and that there's a reason why we use certain sutures in certain areas. Post-op fever. All right, so what's the definition of post-op fever? It is the presence of a temperature of 100.4 or greater on 2 occasions, at least 4 hours apart, excluding the first 24 hours post-op, or one temp greater than 101.5, excluding the first 24 hours post-op. Why do I keep saying excluding? Early fever, especially in the first 24 to 48 hours post-op, is primarily due to tissue damage. The damage that we cause to the tissue causes a release of cytokines and prostaglandins, and it causes temperature elevation. So that's what's really tough early on, is to try to figure out, is this truly just a cytokine response, inflammatory response, or is there a true infection going on? Any infection that occurs 4 days or greater after post-op day 4 or greater is most likely an infection. And then if it occurs after day 1 and until day 4, that's where it gets a little bit tricky, and you're going to have to evaluate it. You're all familiar with the wind, water, wound, walk, wonder drugs, and I don't need to read through this, you know that. So again, how are you going to work it up? You're going to follow your wind, water, wound, walk, and wonder drugs. You're going to do an exam. You're going to check vitals and lungs, and you're going to check for CVA tenderness. You're going to check the abdomen. If you've done an abdominal procedure, say an abdominal hysterectomy, don't forget there's 2 incisions, a vaginal one as well as an abdominal one. You're going to check extremities. Different tests that you're going to do are all listed here. Somebody with a post-op fever does not need all of these tests, but you should be very comfortable if you have any patients on your case list who had a post-op fever and you gave them a diagnosis. Tell me how you diagnosed them and what you diagnosed and what did you do to work them up. If somebody has a fever and you're really not sure where it's coming from, tell me what you're going to do and how you're going to evaluate them. So look at your case list and be comfortable with anyone who had post-op fever of what was your initial diagnosis, what was your differential diagnosis, and how you evaluated and then treated them. Here's some miscellaneous pearls. All right, drug fever. I've actually had, I can think of 2 different patients who had drug fever. They're sitting there post-op and like it's day 5, 6, 7, and I can't let them go home because they keep getting these weird spiking temps, but they look fine. And that's what I found very stunning. So what happens is they can get eosinophilia about 20% of the time. The patient definitely appears clinically better than the temp suggests. You've ruled out abscess, you've ruled out everything else, and you're truly stumped. Review the medication list, and stopping the medication will make that fever go away. Now, consider septic pelvic thrombophlebitis. So septic pelvic thrombophlebitis, we typically much more commonly see in our postpartum patients, especially after a C-section with endometritis, parametritis. It is usually on the right side. And these patients will develop, they have persistent fever even after 3 to 5 days of appropriate antibiotics. You've ruled out abscess, you've ruled out other causes. Their white count can be elevated, usually greater than 12,000. And so heparin or low molecular weight heparin can be both diagnostic and therapeutic in cases of refractory fever of unknown cause. You can do a CT with contrast or gadolinium enhanced MRI, and you can make the diagnosis of septic pelvic thrombophlebitis. It can occur after GYN surgery. It can occur in patients with malignancy, and it is treated with gentamicin, clindamycin, and anticoagulation. So think about that when you're kind of stumped. So what I was going to do, my plan was to stop here and then we would start in on pelvic floor defects tomorrow. So I think, and we're right about spot on. We've got about 2 more minutes of lecture. You know what I'm going to do? I'm going to come back to start here, but I do want to let's use up a few more minutes of our time. Pelvic organ prolapse. There's actually a very good practice bulletin on pelvic organ prolapse I would highly recommend that you look at. The removal of the uterus does not completely address uterovaginal prolapse. So here, this is something that, again, if you were going to do a TVH for somebody with total procedentia, and I want you guys to think about this overnight. Here is the cervix. Here's like the bladder and the anterior wall of the vagina. So everything is inside out not upside down, but it's inside out. So if you think about where the opening of the vagina was, and here is the anterior wall of the vagina and the bladder sitting above it, now it's all come out this way. So the ureters are actually like around here. So that's where, if you were going to do a TVH, you have to be very aware of that and very careful. This is an example of a post-hysterectomy vaginal vault prolapse, and this is, of course, what we want to avoid. And so tomorrow we will address the pelvic organ prolapse and the defects there. So now let me stop here and look at any Q&As. So does anybody have any questions? All right. Well, then, you know what? I'm trying to think if I should just continue on. Let me just double check and hey, Lou.
Hey, if you don't have any questions, then we will end for today.
Okay.
And